All right, let's dive right into a really high-stakes topic today, plasma exchange for patients with liver failure. We're talking about some of the absolute sickest people in any hospital, and the treatments we have can be pretty intense and, honestly, pretty controversial. So let's get into it. And that's really the million-dollar question, isn't it? When you're dealing with a condition where the mortality rate is just terrifyingly high, you have to look at every single option on the table. And therapeutic plasma exchange, or TPE, is one of those options. But its role, well, it's not as clear-cut as we'd like. Okay, first things first, let's just quickly level set so we're all on the same page. We're discussing two different but equally catastrophic situations. You've got acute liver failure, or ALF, which is when a totally healthy liver just suddenly gives out. Then there's acute-on-chronic liver failure, ACLF, where someone with long-term liver disease suddenly crashes and their organs start failing. Both are absolute medical emergency. So here's how we're going to break this down. First, we'll talk about why we even do this. Then we'll get into how it works, the mechanism. After that, we'll look at the evidence. Is it real hope or just hype? And finally, we'll cover what it looks like in practice, the risks and the rewards. So let's start with the core question. In the whole treatment plan for liver failure, where exactly does something like TPE fit in? At its heart, you can think of it as a life support system. For patients lucky enough to be a candidate for a liver transplant, TEP can act as a bridge. It keeps them alive and stable just long enough to get that new liver. For everyone else who isn't a transplant candidate, it's used as part of a Hail Mary medical strategy, hoping to give their own liver a fighting chance to recover. All right, now for the cool part, the science. How in the world does this actually work? The best way to think about it is like a complete system reboot for the patient's body. The process itself is pretty straightforward, conceptually. You take the patient's blood out of their body, spin it down to separate the plasma from the blood cells. That plasma, which is just full of toxic junk, gets thrown away. Then, the patient's own blood cells get mixed with clean, fresh frozen plasma from a donor, and it all goes back into their body. It's basically a massive oil change for your blood. So what are we actually pulling out of the system? Well, it's this whole toxic cocktail of pro-inflammatory molecules. See, in liver failure, the body is just flooded with things like cytokines, these things called DAMPs from dying liver cells, endotoxins leaking from the gut, and toxic bile acids. These are the bad actors that are driving all the other organs to fail. TPE literally just yanks them out of circulation. And this quote right here, it just perfectly nails the goal. You're not directly fixing the liver. You can't. What you are doing is cleaning up the toxic mess in the bloodstream. That calms down the body-wide inflammation and stops the damage to other organs. And this, hopefully, gives the liver a little breathing room, a chance to rest, regenerate, and maybe, just maybe, start working again. Okay, so the theory is solid. It makes perfect sense. But does it actually work when you put it to the test? Now we get to the clinical evidence, and believe me, this is where the arguments really start. Let's start with acute liver failure. The data here is fascinating, mainly because we have some really good studies that came to completely opposite conclusions. Pay close attention to this slide because it's critical. On the left, you have this big European trial by Larson's group. It showed a clear survival benefit in patients who didn't get a transplant. Awesome, right? But then, on the right, a more recent UK study from Burke's group found absolutely no survival benefit. Now, here's the kicker. Both studies saw improvements in lab numbers and clinical markers. So the bottom line is, everyone agrees TPE makes the patient look better on paper, but we have a huge debate about whether it actually helps them survive. So the picture in ALF is kind of messy. What about in acute-on-chronic liver failure? This is a different beast, with chronic disease underneath it all. Does TPE help these folks? This idea of a golden window is absolutely crucial here. The data really suggests that for TPFE to have a shot at working in ACLF, you have to start it early. We're talking within the first couple of weeks after things go south. The whole point is to jump in before that inflammatory firestorm causes irreversible damage to all the other organs. And if you want a number that'll really make you sit up and pay attention, look at this. One study found that in a very specific slice of ACLF patients, the ones with a MELD score between 30 and 40, TPE took their 90-day survival from a dismal 14% all the way up to over 50%. I mean, that's a massive difference. It suggests that if you pick the right patient at the right time, the benefit could be huge. But, and this is a really big but, we have to be careful.
A lot of this promising data comes from studies in Asia, where hepatitis B is the main driver of ACLF. We have no idea if those results translate to patients whose liver disease is from alcohol or fatty liver. Plus, sepsis is a huge trigger for ACLF, and since TPE pulls out good things like antibodies too, using it on an infected patient is a real worry. We just need better, bigger studies.
Okay, let's switch gears and bring this all back to the bedside. If you're the one managing a patient who's getting TPE, what do you really need to be watching out for? Look, this is not a risk-free procedure. The citrate they use to keep the blood from clotting can actually suck the calcium out of the patient's blood, causing serious hypocalcemia. You can see big drops in blood pressure, allergic reactions to the donor plasma, and of course, anytime you have a big catheter sitting in a vein, you worry about infections. You have to be incredibly vigilant. So here's one of the fundamental problems with standard TPE. It's kind of dumb. It's like fishing with a giant net. Sure, you catch all the bad fish, but you also catch all the good ones too. It pulls out beneficial stuff like albumin and antibodies right along with the toxins. And that has led people to ask, can we do this better? And that question brings us to these combination therapies. People are trying to make the process smarter. You can combine TPE with systems like DPMS, which is basically a more selective, intelligent filter for the plasma. It's much better at grabbing the toxins while leaving the good stuff like albumin behind. And some studies suggest this combo might actually improve survival over TPE by itself. This is probably where the future of this therapy is headed.
All right, we've covered a ton of ground. We've looked at the why, the how, the evidence, and the risks. So let's just boil it all down. What are the absolute key points you need to remember from all this? Let's just run through them. First, the whole point of TPE is to lower that inflammatory burden that's killing the patient's organs. Second, when it comes to acute liver failure, the data on whether it actually saves lives is a hot mess. It's totally conflicting. Third, for acute-on-chronic liver failure, the data looks much more exciting, but it seems to be all about picking the right patient and getting started super early in that golden window. And finally, the next evolution is probably these smarter combination therapies. And that really leaves us with the ultimate clinical challenge. TPE is a seriously powerful tool, but it's clearly not for every patient with liver failure. The real puzzle that we still need to solve, and what future research has to focus on, is figuring out exactly how to select the right patient at the exact right time to give them the best possible shot.